Hello everyone, welcome to today's Care England webinar. Thank you for joining us. Whether you're a provider, a leader, a registered manager, a commissioner, or part of a wider system supporting people with mental health needs, we really appreciate you taking the time to be here today. Today's session is focused on the Mental Health Act 2025, one of the most significant reforms to mental health legislation in decades. And crucially, we're going to hopefully take you through what it means in practice for adult social care today. So with royal assent granted in December 2025 and phased implementation now beginning, many of you are probably already asking some very practical questions, such as what does this mean for changes for services operating within the community? What does it mean for providers supporting those with complex mental health needs or learning disabilities and autism, for example? And what should organisations be doing and how should they prepare even while much of the detail is still emerging? So at Care England, we are particularly concerned with how major policy reforms land at the front line, how they affect you guys on a day-to-day basis, in real services with real people, and in systems already under considerable pressure. So this session really today is about helping you to make sense of what is changing, what is likely to come next, and how you can start to think strategically about preparedness, workforce capability, governance, and collaboration with mental health partners. And we're really pleased to be joined today by Anita Rao, partner at Hempsons LLP, who's been closely involved in supporting providers across the mental health and social care sector within the legal and operational implications of the Mental Health Act reforms. Anita's going to give us a clear overview of what the Act is designed to achieve, where the most significant implications are for social care providers, where they lie, and where providers should focus their attention on as implementation really unfolds over the coming years. Anita, before we dive in, would you mind briefly introducing yourself and your work and perhaps a little about the type of providers and services you support?
Of course, thanks so much, Richard. I am Anita Rao and I work in what we call the advisory team, which probably doesn't mean a huge amount, I'm sure, to many of your clients, but what we deal with are issues to do with vulnerable service users, whether they be children, whether they be adults, and we support organisations across the range of health and social care providers, particularly domiciliary care providers, big residential homes, small residential homes, mum and pop institutions, that full range of providers. And our mission within the advisory team is to try and make law accessible for all of you. And I know particularly with this webinar today, the Mental Health Act can seem like a very daunting thing. So what we're looking to do is really break it down and reassure you that there's nothing to be afraid of in its implementation and to give you some food for thought in how to do that going forward.
That's fantastic. Thank you, Anita. And I think it's great that you cover the whole of social care. So you've got lots of perspective on this. So I think now we need to set the scene for everyone who's joined us today. Could you start by giving us a high-level overview of what the Mental Health Act 2025 is trying to achieve and why the reform is seen as such a significant moment for the sector?
Absolutely. I think the short answer is it brings the framework of mental health law up to date. And many of you will remember 1983 when the Mental Health Act was first passed. And from that time, there haven't really been that many changes to it. There were some minor amendments made to the Act in 2007, but from even around 2017, people realised that the way that we approach mental health and the perspective we had in 1983 was no longer fit for purpose. It didn't reflect contemporary societal values. It didn't reflect how we approach issues of mental capacity. And quite frankly, it didn't approach how we approach patient care and care of service users, even those with disabilities, which has been a development over the last 30 to 40 years. So what this Act, which received royal assent, as you say, in December, has finally sought to do is to bring it into line with what we would expect an Act that treats people with respect, empowers them, and gives them a proper voice in their own care and treatment, what we would expect that to look like. And the aspiration of the Act is to, I think, do four main things. The first of which is to empower the patients who are receiving treatment and detained under the Act. And it does this in a number of ways. Firstly, promoting advanced decision making, because many of these patients will, for example, with cyclical conditions, go through points of clarity, lucidity, and will be able to make decisions about how they would then like to be treated under the Act. And it empowers them to be able to do that in a more proactive way going forward. It gives patients choices over their nominated persons, who are the person who would then represent their interests in front of a tribunal. The 1983 Act talks about nearest relative, which maybe then was the right way of thinking about it. Maybe if I'm detained, for example, my husband's perhaps the first person who has that right, then my children, and then my mum. But say, for example, I don't have a great relationship anymore with any of those individuals, then why don't I have the right to choose? And this Act respects exactly that and looks to give that person who's nominated an expansion of their powers and an expansion of the range of decisions that clinicians need to consult them on. So they're really much more integral to the process, and they're chosen by the patient. And finally, there's a widening of the role of independent mental health advocacy, which is going to have significant consequences, I'm sure, for a number of the providers as they have to assist in accessing that. But again, it's all about empowering the patient. The second major shift is about improving access to the tribunals and its procedures in terms of giving patients access. It will be more frequent, and the tribunal's powers are greater in a number of ways I won't go into right now, but which again is about ensuring regular and effective review of care packages and making sure that where things aren't going to plan, the tribunals are able to scrutinise care and treatment plans and hold public bodies to account where they're not being provided perhaps as they were intended to be. That third shift is moving treatment from a mostly hospital base to community base. Hospital will now then be reserved for what they call the most serious cases, and a huge range of other patients, particularly those with learning disabilities and autism, who we've seen in the news. There's been a long history of them being detained as a result simply of those conditions. Their care is to be, when this plan is fully implemented, moved into the community, even in more complex cases. And that's a major shift in the Act and how it treats conditions by making that shift. The last major shift, I think, is it really advocates a more principled approach. It's not that the approach to date has been unprincipled, but rather that it sets out 4 key principles that should be borne in mind by everyone who are making decisions under that Act. And those are choice and autonomy, least restriction, therapeutic benefit, and seeing the person as an individual. Some of you will probably recognise some of these themes from key principles of the Mental Capacity Act, but fundamentally what it is all about is giving a clear structure to decision making under the Mental Health Act in a way that mirrors how we, if we were ever detained under the Act, would like to be treated, which is having the opportunity to have a voice and having only measures that are to our therapeutic benefit, least restrictive, and treating us as individuals.
Thanks, Anita. That's really, really helpful. It's a helpful way of setting out both the ambition behind the reforms and the scale of what's changed since 1983. That was such a long time ago, and really helpful to understand the variability of conditions, because people are not always stable. People do have variable conditions. So it's great that the Act picks that up. And hospital to community is very much now, because it's part of the NHS 10-year plan. These are things we need to think about. I think the themes you outlined around people being seen as individuals, empowerment, least restriction, and stronger focus on rights, choice and autonomy will clearly resonate with the direction of travel that many providers are already trying to work towards. This is what we've been trying to do. So at the same time, as you say, the real test will be how these principles translate into practice in a pressured, complex system, of which is certainly from our perspective, adult social care. So bringing this into the real world of adult social care, what do you see as the most important ways the Act will affect providers who are supporting people in the community?
Absolutely. And I think there are 3 general themes that really emerge from the Act. And in a nutshell, they are, firstly, I think there's going to be a greater complexity of need in the community. So patients with more complex mental health needs will be cared for in the community, which then changes perhaps the user base who are using the services or providers to date. The second major shift, I think, will probably, there's going to need to be a much greater depth and strength of inter-provider and inter-organizational working. And what I mean by that is that for patients who are receiving treatment under the Act in the community, it's going to be absolutely central for community mental health trusts and providers to be working hand in hand to ensure that person's mental health needs are met within the context of the care that they're receiving, but also to escalate crises, to have conversations, to support that patient, often with them as well, and to ensure everyone's speaking from the same sheet. The last focus, I think, is going to be a real lasering in on patient empowerment, which I know for many providers, as you say, will be second nature and something they're already looking to achieve. So I'm hoping that won't feel so much of a sea change. But interestingly, because it is such a sea change for the way people are treated under the Act, it will be interesting to see how that focus on patient empowerment within the context of the Mental Health Act translates into differences in terms of how these patients can then be cared for in the community. So from those 3 points, though, I think the first thing I would say, as sort of caveat to the whole thing, is I do think the impact of the Act is going to be uneven. And so I think that for some providers, for example, perhaps someone who runs a retirement village with persons who don't have any needs under the Mental Health Act, there's no prospect perhaps of them being detained, and they're more attending to a supported living, facilitated living environment, they're likely, I think, to be less affected than some providers who are caring for, say, complex children and young people with diagnoses of learning disability and autism, and also complex adults with that same diagnosis, where perhaps they have behaviours that challenge, but concurrent complex mental health needs that bring them within the scope of the Act. It's much more likely to affect the latter more profoundly than it will the former. So I think it's just a note of warning that everything I say from now is likely to be more relevant to the latter than to the former. But coming then, I think, to the first of those themes, the complexity of need in the community, the Act is expressly focused on setting a threshold for admission to hospital and for assessment for admission to hospital that is heightened. What it now requires is that serious harm is a factor that needs to be considered before a decision to detain is made. It requires that clinicians, whether the condition from which that particular patient is suffering is treatable, and it asks them to consider whether, given the nature, degree, and likelihood of harm, that it's necessary for that person to receive medical treatment in hospital. Crucially, what they mean by that is that the treatment can't be provided unless they're in hospital. So some may say, will this lead to any difference in practice? I'm sure there are many doctors out there who will say, that's the threshold I'm applying anyway. But I think certainly what the Act is trying to do is make absolutely clear that it is going to be a pretty high bar to admission to hospital. And assuming that it does have some impact on the numbers of patients who are then cared for in the community, it's likely that the complexity of those with needs in the community is just going to increase. It may include some people who, for example, have non-treatable mental health conditions, for example, or whose conditions are treatable in the community with sufficiently intensive resourcing. I think from a provider perspective, the key thing there is to bear in mind that where you're working with these groups already, it's likely that instead of having more individuals with simpler needs, as it were, although I appreciate it's difficult to describe anyone in that way, but the complexity of the need that you will be facing on a day-to-day basis is likely to be much higher. And I think the key question that providers need to think about now that would serve them very well for the future is, how can you prepare for this? Many of these provisions of the Act are happily not being brought into force now, but that is very much because the resourcing that is going to be required on a number of fronts both from ICBs in terms of commissioning, from local authorities in terms of commissioning, from providers in terms of being able to ascertain where they fit into this overall framework of provision. It's going to be intensive. And the ambition of bringing every individual who has learning disabilities and autism out of treatment into hospital, given the levels of current diagnosis, it's a very laudable aim, but one that is going to take an even greater level of resource in the future. So from a provider perspective, I think there's going to be a few points that it would be useful for them to start thinking about now to prepare them for the world in which these resource decisions are going to be made. Firstly, are you one of the providers who are going to be most affected by this? Do you want to move into that sector? Is the acuity of need that you're already seeing in the community reflective of what I'm describing, or is there likely to be a change in the presentation of the people that you're working with? How can you think about preparing for that? 3 examples that came to my mind were, can you work out which of those services you're providing are going to be most affected by this change, and how? If you don't already have a working relationship with your community mental health trusts and know where your Section 136 suites are, know where your places of safety are, can you do that? Can you start building those relationships now? And the last point that came to mind was, do your staff need a bit more training? We all know that training is one of those things that takes time to embed, takes time for what you've learned to become practice. Do they need more qualifications to support that training? And can that be incorporated in your training programs then over the next few years? Because the advantage here is this isn't happening tomorrow. The impact on the social care sector is likely to be seen down the line. So it's about thinking about how we can prepare now, very practical steps and measures.
That's incredibly helpful, Anita. And I think certainly when you talk about the training, I can hear lots of providers taking that sharp intake of breath, because I know we've had the Oliver McGowan training, we've got a lot of training. There's a lot of parts of the sector wanting to really push training on us at the moment, and it's a huge issue because it's a huge investment in taking the workforce out of work to backfill and to do. But you're absolutely right, there's going to be some training, and I think kind of what will resonate with many providers listening is that sense of uneven impact. And for parts of the sector already supporting people with complex needs in community settings, it doesn't feel like a distinct policy shift. It feels more like an intensification of pressures that are already being felt day to day. And I think the point you made around, you labelled it theme 1, complexity of need, about relationships with community mental health teams, workforce capability, and being honest with services that are most likely to be effective, is particularly important, because that's one of the challenges we have around integrated systems and systems working together. It really does reinforce that this isn't something providers can wait to react to. Once the full timetable is confirmed, it's even just starting to have those internal conversations now about skills and partnerships and readiness, really likely to make the difference, so that when the changes come into force, they're already prepared. And I know you touched on the fact that there are some other shifts in the Act that are much closer to things providers are already doing day to day. The second theme I think you said were about organisations, providers working closer together. And the third theme, I believe, is around advanced decisions. So I just wonder whether you could maybe talk us through some of those, please, and give us some ways in which they're going to impact providers.
Absolutely. And I think you rightly pick up on the fact that I think that is very much picking up on what providers are already doing and just putting a little bit of a different lens on it. Because it seems that when these legislative changes come, if they're a surprise for providers, it doesn't help anyone, least of all the staff that have to work with complex service users against this very highly pressured background in any event. And so I think in terms of food for thought, that the other 2 main points I thought would be useful for providers to think about, which builds on what they're doing already, is firstly the note that care and treatment plans for individuals who are being treated under the Mental Health Act are now going to be put essentially on a statutory footing. So where you have individuals who are liable to be detained, say for example someone's at risk of that and that's flagged on a local authority register, or perhaps someone who's already been detained but is now under a community treatment order, or more rarely, someone under guardianship. In the vast majority of those cases, what the Act is looking to do is to put a legal duty on that person's future responsible clinicians or actual responsible clinicians to prepare and regularly review a care and treatment plan for that person. And what's really important is that document will need to be a therapeutic, individualized document. And at an absolute minimum, what it will need to set out is a plan for meeting that person's needs arising out of or related to a mental disorder. And many of your providers who are working with patients of this kind will hear echoes of Section 117 there. And once that's put on a statutory footing, what responsible clinicians will be required to do is to ensure that is available for all patients liable to detention under a CTO and under guardianship. And for social care providers, one of the themes the CQC always picks up on, in my experience, is, do you know what your patient's care plans are? Do you know what care they require? And it strikes me that this is exactly the sort of care plan where if you had a patient with this level of complexity, you should be having on your records, and you should know how your care plans and the care you're providing on a day-to-day basis interact with the individual's care plan meeting their needs arising from or related to a mental disorder. So I think that is a really important point that it would be good to bear in mind now, because if your staff get used to asking once they see someone, or maybe actually you might be subject to the act, get used to thinking and asking for that care plan. It will become second nature by the time this provision is implemented, and it will benefit them because it won't feel like a surprise all of a sudden, and will benefit the individuals as well who are receiving that care by showing that the provider is able to pull together all those various different aspects of their care and provide a unified care package, which is at the end of the day something that the CQC is very hot on and likes to look for. It's a bonus for everyone, I think, to start thinking about that now, and really just picks up on a theme I'm sure many are already picking up on in their preparedness work for inspection. The other sort of, again, picking up on a similar sort of thing in recent years for the CQC has also been about planning for the future. And that can be, for some people, end of life planning, but for other people, it could be about planning to take your next steps towards adulthood. So, for example, someone learning a particular skill or taking on a part-time job, because that's as much their future as someone toward the end of their life. But where you're thinking about those issues with a patient, what I would suggest is think about advanced decisions. Think about whether or not that patient is the sort of patient who might want to make an advanced decision about their care and treatment. And your providers will be aware, advanced decisions aren't new. They've been around for a very long time, but I think they've been relatively underutilized. But they can be a really powerful tool for allowing people who have those cyclical sorts of conditions, but also people who are perhaps currently, they've got capacity, but are looking down the barrel of a condition that is likely to impact on their capacity profoundly later down the line, and they may need detention under the Mental Health Act. You're giving them the power now to determine what they would have done or not done to them. Future planning, advanced decisions in a more general way. If this could start to form part of the matters that you discussed with those sorts of service users, then again, you are setting your staff up for success then, as and when more and more of these patients are coming into the community to be cared for. And as providers, you're uniquely placed to pick up on that person when they're having a good day. They're not likely to encounter many other people, whether it's the GP or the acute trust or anyone else, when they're having a great day and able to make those decisions. So you have that unique power to do that. And I think if you demonstrated foresightedness in thinking about that and discussing it with your users, that would again be something that the CQC would be complimentary of, because it demonstrates that you're helping them plan for their future.
Really, really helpful. It's useful to hear that some of this builds on areas providers will already recognise from CQC expectations, and around the kind of the person-centred care and planning for the future. So it's really expanding on that. But preparing and regularly reviewing therapeutic and individual plans is business as usual for care providers. I speak with one of your colleagues, Philippa. Things don't always change. We've got to do what we keep doing, but we've now got this statutory duty that kind of just makes it a bit more robust. So the statutory duties, I think, that really strengthens that. And I can see some local authorities will be pushing providers further on this, probably as will the CQC. So getting used to asking for that, the plans, and it's really great advice to reduce the impact when it really comes into force. And I think the unified care package, many providers will be doing already, but equally many will not to a satisfactory level. Point really well made there. I think the point you said around care and treatment plans being much more explicit and needing to be properly understood and reflected in day-to-day care feels particularly important, as does the more intentional reference around advanced decisions, because we always tend to think advanced decisions are about people's end of life. But of course, when we've got people with learning disabilities and autism, we're talking about their full life, 30, 40, 50 years or even longer. Having those advanced decisions rather than seeing them as an optional extra, I think is really important. And that also reinforces that while it is a new law, much of this is good practice and it will be very familiar to people. So it's not, we're not reinventing the wheel here. We're just seeing a reinforcement of kind of what many are already aware of and doing. But it will need to be done more consistently and more confidently across services. I think that's come across clearly. That statutory duty again just raises the profile. And I'm sure many will, have this duty waived in front of them, be that sort of providers, commissioners, the CQC or families. It's very important to understand exactly what we're doing and how we need to kind of strengthen what we're doing. I think that's what I've picked up from you today. So another question I do have for you is that if you were speaking directly to a registered manager, a provider, a CEO listening today, what should they be most aware of over the next 12 to 24 months? And where should they be focusing their attention to be in the strongest and best possible position?
That's a great question. I think the first thing I would say is don't panic. The provisions that are coming into force later this month are very niche and are very unlikely to affect the social care sector. And we don't have a timescale for implementation for the rest of the Act. Some conversations within the industry are suggesting that it will happen over the next 10 years. But as I say, it's very resource dependent. If I was speaking to a CEO or registered manager, I think my emphasis would be on really pulling together the strands of what you're already doing, because the Mental Health Act really just underlines the work you are already doing in preparedness for inspection and ensuring you deliver the best service to those people who you work with. And having a sort of antenna up to try and recognize where you see a patient who might have been detained, who might have been owed a 117 duty, who you think who might in the future need intervention under the Mental Health Act. I appreciate that as social care providers, you have a huge number of roles already, and I don't mean to impose any more on that, but you as a staff on the ground will know when you've got someone in front of you who you think, oh, actually, I think that person might be having a bit of a crisis or is on a road to that. And so if you can have an antenna up to that person, build those relationships locally and start to think about their needs in a more holistic way and bring those other relationships from local commissioners, local acute trusts, local community bodies. If you can start those together now, when the Act comes in, it will be business as usual for you to be thinking about it. But I think I'm very conscious that this is a longer term view. And so the other thing I think I would say is just to come back to what I said initially, which is don't panic. If you can't do that this year, that's okay. It's about starting to think about it so that over the next 5 to 10 years, as and when we know more about when this will be brought into place, you're already doing the things that you would aspire to do now. And then the Act simply solidifies it with a legislative backing. That's all. It won't change how you do those things. But I feel it's always good when you have the advantage of time to use it so that you can manage all those pressures in a way that's sustainable for you and your staff.
Again, incredibly helpful. Don't panic. I take that one away. I like that. I think sort of Stephen Covey says, start with the end in mind. So knowing what is required, then starting to build toward what do I need to build on feels like really good advice. And it's really reassuring for providers to hear that the immediate changes coming into force aren't ones that will land directly on social care overnight. And at the same time, the direction of travel you've outlined is clear, and it gives providers some much needed thinking space around what's ahead and how that's going to impact workforce partnerships and community-based support. And we'll need to evolve over time, but it's not instantly. It's not day one, we've got to implement, we've got to do this over. It's a journey, not a destination that we've got to get to. and where we just really need to build on what we already do. I think that message comes through really clearly is don't panic. You're probably doing a lot of this. You probably just need to build on it a little bit. So it's been incredibly helpful. Thank you very much.
Not at all. It's been a pleasure to be here.
Thank you again for sharing your expertise and practical insights with us today. And thank you to everyone who has joined us. We hope today's session has been useful in helping you to think about what the Mental Health Act reforms mean for your organisation and the people that you support. We will be sharing follow-up resources after the session. We encourage you to stay connected with Care England as we continue to work through these implications. And we want to thank you again for joining us today. We'll make sure that Anita's contact details are in the notes accompanying the video. Thank you very much for your time today. Bye-bye.